Good afternoon, everyone. I'm Will Jones. I'm the Director of Community Engagement and Outreach here at SAM, and I want to introduce you to our speakers today, and we'll be discussing supervised consumption sites, ineffective and illegal. We have Dr. Kevin Sabet here. He's the co-founder and CEO of SAM and FDPS, National Drug Policy Organizations. He was dubbed by NBC News as the prodigy of drug politics and served in 3 presidential administrations as a drug policy appointee over the course of his 25+ years in the field. In 2025, Dr. Sabet released his latest book titled One Nation Under the Influence, America's Drug Habit and How We Can Overcome It. He's been profiled in the Free Press, Unheard, Politico, Crane's Business, Salon Magazine, the International Business Times, the Daily Beast, Vox, and many other publications as America's point person on drug policy issues. I'd also like to introduce Charles Fain Lehman. Charles Fain Lehman is a senior fellow at the Manhattan Institute and senior editor of City Journal. He focuses primarily on the public policy of antisocial behavior, including issues of crime, drugs, and public disorder. His work has appeared in outlets including the New York Times, Atlantic, Wall Street Journal, and National Review. He has discussed policy issues before the Senate, House of Representatives, and the U.S. Commission on Civil Rights. Prior to joining the Manhattan Institute in 2021, Charles was a staff writer at the Washington Free Beacon. Charles is originally from Pittsburgh, Pennsylvania, and now lives outside Washington, D.C. with his wife and sons. So those are our speakers for this afternoon. They have a lot of great information, data, and research to share with you all. And I just want to, before passing it over to them, just give a few words also as why I'm interested in this topic and working here with the organization SAM and FDPS, talking specifically about safe injection sites. I've seen in my career, I've served as a firefighter in DC for 9 years. I was a sergeant with DC Fire and EMS, and a lot of people don't know this, but one of the 3rd busiest firehouses in the United States is actually here in Washington, DC. It's on the other side of DC, over by Minnesota Avenue, and I worked there for 9 years. And during that time, I saw the impacts of drug policy firsthand. And so when I'm here talking about this issue, it's not for me just a policy thing, talking about policy points or data points that I've read in a paper or a journal somewhere. This is something that I've actually lived. This is something where I've given, we're going to talk about Narcan and giving out for overdoses and things. That's something that I've done for almost a decade here, one of the busiest places in the U.S. to do this. And so I think it's incredibly important that we inform our decisions from a policy perspective about what's actually happening on the ground and what the data and the research says, and that everything's aligned with that, and not to give away what's here, but we're going to see a lot of money has been invested in some of the safe ingestion sites, and a lot of this is in the folders that you have here. Definitely recommend reading that. But when we're talking about the impact in communities, 2 things especially that I think we need to be aware of is the impact of having these sites in places where sometimes putting these there is against the wishes of the community. So if we're investing significant funds like this in something that, and we'll hear this in the data hasn't really shown to be effective, but we're placing it in certain communities anyway, we really need to look carefully at that. And so Dr. Sabet and Charles are going to dig deeper into that and share really more of the deep research and the data behind this. I think that we're going to all learn a lot from that this morning. Thank you.
Great. Thanks so much. Thank you, Will. It's really a pleasure to be with all of you today. It's really an honor to be sitting next to Charles, who's, I think, one of the best thinkers currently in our country, thinking about the complexity of this issue. It seems like this is an issue, drugs, that everybody has an opinion on. I only wish it was an informed opinion, but usually it's not the case. So we're lucky to have Charles here, who thinks about this and writes on this full time. And really to all of you here as well, and those of you who are watching on our live stream, we want to welcome you to talk about really an issue that it's a difficult issue to talk about because, we've lost so many people to overdoses. At the peak, over 100,000. That's probably an undercount because we don't count deaths that great in this country. We count them better than we count other things in drugs, but it's still not very good. But we have seen a reduction recently, which I think is very heartening, about a 30 to 40% reduction, depending on what year you're looking at, which, there's all kinds of theories about what that is. We're not talking about that today. We're happy to, maybe if you want to field a question, Charles and I can play with that a little bit during the Q&A. But, this is an issue, supervised consumption sites that, really come from in some ways, desperation. I mean, losing so many people, and how fentanyl has completely changed the game with the synthetic drugs that we have in terms of quickness of overdose and what we've seen. It really has driven people, I think, to some solutions like this one that really don't have a lot of evidence behind it, even if it's well intended. What I wanted to just chat with it for a few minutes, kind of lay the groundwork for, and then I'll hand it over to Charles to kind of talk about the specifics of this report, is really kind of this idea. Let's see if this is going to work. Nope. So here, how do we do that? Where should we point it? Okay. You can also do it too. Point it at the laptop. That's what I'm doing. Okay. Well, we'll work at that. But basically, it comes from this idea in drug policy called harm reduction. And actually, I'm curious how many people here have heard of the term harm reduction before? A couple people, yeah, about half the room. And harm reduction really is this idea that we want to not only reduce the prevalence of drug use, but we actually want to reduce the consequences that come as a result of drug use. So, the main consequence that we talked about for so long in the 80s and 90s was really HIV and hepatitis. That as an injection drug user, really injecting heroin, and in some ways, doing that with cocaine sometimes, but really the opioids, namely heroin, that you were increasing your risk of a bloodborne disease because you were sharing needles. And so this idea came about really from that era. And it was this idea that we wanted to meet people where they're at. You've probably heard that term before. And of course, I think implied in meet people where they're at is this idea that we're not just going to go to somebody who's addicted to, who's been a 20-year addict to heroin and say, you need to go to treatment tomorrow or you're going to go to jail. Because, first of all, you have to detox, getting ready for treatment. It's a whole process. So it's this idea that, while we're waiting for them to get ready to go into treatment or hoping that they will realize they have a problem to go into treatment, it's this idea that we want to at least reduce the harm from their current behavior and, for example, provide clean needles, the needle exchange programs, for example. And that was the idea. And I think, where we're coming at it as an organization, the Foundation for Drug Policy Solutions, which is an organization I founded with Luke, who's here, as well as former Congressman Patrick Kennedy, is that we do want to meet people where they're at, but we don't want to leave them where they're at. And I think that part of it has been forgotten, because this idea of only focusing on harm reduction, implied in that is that, we can sort of reduce harm so much so that we can have a, sort of a situation where you can use drugs safely, where you can use opioids in a safe manner, i.e. less likely to overdose. So for example, if you do it with friends, you're less likely to die because one of them who you're hoping is probably of sound mind, who may not be, but you're hoping is, would, call for help or administer Narcan for you. Or it's this idea that we can use drugs more safely. So rather than inject drugs with a dirty needle, we hope you inject it with a clean needle. That's where this comes from. Or this idea that, well, we'd rather you smoke drugs than inject them. Like we'd rather you smoke heroin, for example, than inject it, or smoke cocaine, like in the form of crack, than inject it, because if you inject it, you're more likely to get a bloodborne disease. And by smoking it, you don't get a bloodborne disease. And that's really where, harm reduction kind of took off. And I think what we're trying to say is that there's a place for harm reduction, certainly. For example, Narcan is harm reduction. When you give somebody, when you revive them in an overdose, that's a form of harm reduction, because you are reducing the harm of their drug use. You're not necessarily stopping them from using drugs right there, but you're saying the harm from drug use that you just experienced, overdose, and you might die, we're going to reverse that. We're going to reduce that harm. Or again, this idea of a clean needle is a reduction of harm. Or you can argue methadone maintenance, which is one of the oldest opioid treatments we have, is a form of harm reduction, because methadone is an opioid. It's just a different kind of opioid. And the brain thinks it's very similar. That's why it's useful, because you're using methadone and not heroin. And that's kind of a way to do harm reduction, so that we can reduce harm from your heroin use, give you methadone. But what we've really seen, I think, is this very quick slide from, maybe I would call it sensible harm reduction, I guess you could call it that, to more extreme harm reduction. And that extreme harm reduction has seen itself in like decriminalization of all drugs. So we're not here to talk about this today, but states like Oregon have tried that. It was a complete disaster. They reversed it. Their very liberal Democratic governor signed the reversal after promising she wouldn't, but she had to sign it because all of her constituents wanted her to sign it because it was so devastating. This idea in Canada that they have widespread throughout Canada called safe supply, where they say, well, we know you're going to use fentanyl, so instead of that, we're going to send you a free bottle of OxyContin or Dilaudid hydromorphone, something like that, in the hopes that you'll use that. This is their version of harm reduction. You'll use the pill and not use fentanyl because at least we know what's in the pill. A pill was manufactured by a pharma company and it's not fentanyl. The problem with that, and again, this is not about that, we'll talk about it another time, but the problem with that in practice is that most of the people who are using fentanyl now, they want to use fentanyl. They're not trying to avoid fentanyl. I mean, 15 years ago, yes, the kid who unfortunately overdosed with fentanyl thinking he was taking a Xanax, that was accidental. That's what we might call a poisoning. But the vast majority of overdoses now are from people who know exactly what they're using. And so what's happening in Canada, why they're reversing this actually as we speak, is that the pills that are being sent to the users are being sold on the black market to naive users, because naive first-time users they don't want fentanyl. The naive users for money, and then that money is being used to buy fentanyl. And when you get it free from the government, it's basically the government is supplying fentanyl indirectly. So that's a extreme. And then of course, legalization. And we've never really seen a legal retail market for a drug like heroin or cocaine. We certainly see it for marijuana though, and high potency marijuana. But there are places again in Canada and elsewhere where sort of illegal kind of underground drug user groups are marketing and selling. This is not an AI image. Packets of heroin mixed with caffeine that they're giving away or selling at a small price. The cost of production of these drugs is tiny. So if the reason why the cost of the drugs normally is expensive if you're on the street is because prohibition increases prices, which is a good thing. We don't want these drugs to be cheap. The actual production of crack or these drugs is extremely small. And so when you're actually out there, selling this, you can sell it for very cheap. You won't lose money. So harm reduction then versus now, originally, again, kind of born out of social workers in the early 80s in places we had zero control over HIV/AIDS. HIV was a death sentence. HIV is not a death sentence anymore, but it was. And so when that was the case, it was an emergency. It was we have 300,000 or 200,000 opioid addicts in the UK. We're going to have to give them some clean needles, and we're going to call that harm reduction. This is like 1985, and so that's what we're going to do. But that has morphed into this idea of do whatever you want, whenever you want. And the legalization movement, the people behind legal marijuana and who want to legalize other drugs, they have taken an inch and gone a mile, and they have used harm reduction as a weapon. It's an extremely divisive term even today. In the Obama administration, in the first term, I should say, because that's when I served, we very hesitatingly ever used that term harm reduction because it means a million things to a million people. It was very divisive. And it was in the Biden administration that they said, well, we are going to use it, but we're going to define it. And I give them credit for defining harm reduction as a few different interventions: Narcan, testing fentanyl, and I think needle exchange programs. They defined it but it's still a very, very fraught term, I think, that is very kind of difficult. Like I can't go forward anymore. So there we go. Nope. Okay, so I'm not sure what my next slide was, but we'll figure that out. I'm pretty much done. The issue is, so harm reduction, we see in these interventions as a way to, there is a place for them as an intervention, but not so much as a drug policy philosophy. And when it's taken as a philosophy, it's really taken in a way that is very extreme and leads to things like these consumption sites. These are sites that have started across the country that allow people that say, if you use drugs in front of us, we're fine with it. In fact, we encourage you, come here, use drugs in front of us, and we'll revive you if you overdose. But if you don't overdose, that's okay. You can come back whenever. And they're very proud of it. And they say, well, we don't have any overdose. We have no overdose. It's not working. So if you can fix it, be great. We have no overdose at the actual site. That's what they say. We have zero overdoses, so we're a success. And clearly, I think that's not true. And we wanted to investigate this. So when I talked to Charles about, it's working again, great. When I talked to Charles about this issue, he said, actually, we're writing a paper on this. And I said, great, we're wanting to write a paper on it too. So this was a nice confluence of time and in some ways coincidence, and great minds think alike, I guess. And we're very excited to partner with Manhattan Institute on this. So maybe, Charles, you can go through what we found in the paper.
Yeah,
and this does work now, so use it.
And thank you so much for organizing this, and thank you all for being here. I'll try not to get too in the methodological weeds, but I want to talk a little bit about the research because I think it's important for understanding this issue. And I'll sort of caveat, and I've written about this, my view on supervised consumption sites is there are real potential social harms associated, but if they actually reduce overdose deaths, then it is at least worthwhile to experiment with them. I.e., if they save people's lives, that's a serious consideration for public policymakers. I think there's at least an intuitive argument that they do. They ought to save people's lives, right? Like drug overdose, particularly opioid overdose, is reversible. If you're using somewhere far away from somebody else and you overdose, you can't be exposed to naloxone and get your overdose reversed. If you use under supervision, you overdose, you can get naloxone, you can get oxygen, you can get access to whatever resources. That's the basic idea of a supervised consumption site. And I think here I think that's a shot from the one in New York City. I should note these operate in New York and Rhode Island. There are plans to roll them out in Minnesota, although as we'll talk in a minute, all of these are federally illegal. They're able to operate nonetheless with the sort of tacit blessing of state and local authorities. And the mental model, again, is part of overdose risk is, being in a position where you overdose without somebody seeing you. If you're supervised, you're less likely to die. There's a lot of research on that topic. To editorialize just a little bit, a lot of that research is garbage. And I choose that word advisedly because in a second I'm going to talk about what would make it methodologically sound. The harm reduction movement, as Kevin was talking about, prides itself on being evidence-informed, but I think, unfortunately, it understands evidence to mean anything that can get published in a journal of whatever repute and uses any quantitative or qualitative methods whatsoever. And the reality is that much of the research on this topic produced by advocates of supervised consumption sites and indeed operative supervised consumption sites rely on poor methods for understanding what the sites do. Some of them simply survey people at the site and say, do you like having access to the site? Unsurprisingly, people who go to supervised consumption sites like supervised consumption sites. That's what you would expect. Others, as Kevin alluded to, simply count the number of interventions that happen at the site and infer that this is equivalent to the number of lives saved at the site in total. This gets to how we want to complicate this intuition just a little bit. The first point is that simply reversing an overdose is not the same as preventing deaths in toto, i.e., it is not the same as saying, but for the supervised consumption site's existence, how many deaths would there be? The assertion of advocates is that there would be fewer deaths, but observing that somebody is likely to overdose somebody is less likely to overdose at a site, or that an overdose was reversed at a site, doesn't mean that the total death rate goes down. Indeed, it is entirely possible that the total number of overdoses can go up in proximity to the site, even as they go down at the site. People who use at a site end up using somewhere else later. Their death is can be at best delayed, with no overall causal effect on what is actually happening, on the level of overdose death in a community. That, I think, is one intuition that's important. The other one is that just looking at the supervised consumption site and the people who use it tell you relatively little about, again, the causal effect of the supervised consumption site here as differentiated from the population that utilizes the site. Kevin alluded to earlier this concept of safer drug use. And indeed, there are more and less risky ways to use drugs. All drug use is intrinsically risky, but we can attenuate the risk. But people vary in their underlying propensity to engage in safer use. And one would expect what social scientists call a selection effect. The sort of people who go to the supervised consumption sites are likely to use more safely, quote unquote, in other contexts, even absent the supervised consumption site. In other words, any recovered benefit of the supervised consumption site may be attributable to differences in the people who use the site versus the people who don't, rather than a causal effect of the site itself. Okay, so what do we know in the literature? Again, supervised consumption sites are an experiment. We've been running this experiment for a long time, since 2001 in North America. In Europe for much longer. There's not a lot of really high quality literature. But my assertion is that the bulk of the literature as it exists leans pretty heavily towards concluding, and I want to be specific about this, there is no effect of supervised consumption sites on measures of opioid mortality or most other measures of opioid-related harm or drug-related harm. They don't make the situation, we have some suggested evidence they might make the situation worse. I'll talk about this in a second, but they don't appear to make the situation worse. They don't cause more deaths, but they also don't stop deaths, which is the whole function of the site. How do we know this? I would say there are two kinds of studies. One are studies that compare people who use sites more and less intensively, or who report higher or lower levels of usage, controlling for a series of other variables. Are they more likely to non-fatally overdose, right? These studies don't track their deaths. They just say, are you more likely to overdose writ large? We have a study out of, using, I believe, data from Vancouver, a study in Barcelona. There's a third study, there's a third study in an undisclosed city in the United States. These are all in the report, which I encourage you to read. All three of these find no effect comparing those two cohorts. Again, and I want to, just to make this point, what we are doing there is not, what the researchers are doing there is not saying what is true of just the people who use the supervised consumption site, but they are matching them to plausible controls. They're saying, compared to similarly situated people who don't use the supervised consumption site, what is the effect of exposure to supervised consumption site? And the answer is no statistically significant reduction, and in many cases, fairly precisely estimated zero effect on non-fatal overdose. Then we get to what I think are the best studies in this space, which are looking at the rollout of multiple sites in Canada. And these are two studies, one looking at the rollout in British Columbia and the other one looking at the rollout in Ontario. Well, what they do is they compare health micro areas, areas designated by the province that do and do not receive supervised consumption sites. And they match them fairly specifically on observed and unobserved variables. And I can get into the methods if people have questions how this works. This is like as close to the social science gold standard as you're going to get with this kind of analysis. And these studies both show, again, no effect on overdose deaths at the local health area level, no effect on non-fatal overdoses, no effect on hospital utilization. You get some suggestive results across the literature for emergency medical service utilization, but that's pretty clearly just because people get services at the site rather than calling 911. By contrast, advocates of SCSs generally point to a different body of literature, again, much of which is observational, does not control, almost all of which relies on the single single site in Vancouver that opened in 2001 is the first site in North America, which has been backed by activists come academics who believe in this stuff as a first principle. These studies are pretty reliably flawed methodologically. In the worst case scenarios, they're again just literally surveying people. Even in the best case scenarios, they will make these sort of weird methodological choices, like comparing the site to the whole rest of Vancouver, which is not a valid control group, or selecting like one period of months and then another period of months with no explanation of why they selected the particular periods that they did. In one study, arguably the most widely cited study, on this topic that is supportive of supervised consumption sites, the central estimate has and I'm being a nerd for a second, has a p-value of 0.049. If that doesn't mean anything to most of you, that's fine. In statistics, we talk about statistical significance. Statistical significance is measured by how likely it is that a result was due to chance. As a general rule, statistically significant result has less than 5% chance that it's attributable to chance, less 5%, 0.05. So they find just within that margin, their preferred estimate is right there. That's a huge red flag if you know how to criticize literature. So I will, I don't want to nerd out too much. But the top line, and then I'll let Kevin talk a little about the law. The top line is we've been doing this experiment for a very long time, and we have a lot of evidence. And the evidence really says these things do not work. It makes sense that they do not work because at the end of the day, having a site that serves 20 people to use fentanyl once when the average person is using fentanyl 3 to 5 times a day just cannot make a dent meaningfully in people's risk of overdose. It just doesn't do it. It just doesn't cut it. But they are at least very expensive. And Kevin, you want to talk a little bit about also the legal situation?
Yeah, so there's this funny thing called the law, federal law. And when you look at the federal law and the statute, which actually, I think this language was written by then Senator Joe Biden, which was basically, we call it the crack house statute. So it was really anywhere that knowingly allows for the use and distribution of any drug, that whole establishment can be seized. That whole establishment is illegal. And this was in the mid 80s in the crack epidemic, when, going after, crack houses was pretty much a very bipartisan thing, very good thing. And it was actually updated in the late 90s with what was called the Rave Act, because it was, we wanted, folks, and again, it was Senator Biden actually, who wanted to make sure that places where there were raves, where there were a lot of overdoses due to MDMA ecstasy, that those were also covered under this crack house statute. So it's actually now sort of going in the law, but there was a supervised consumption site set up in Philadelphia.
It's supposed to be the first one in the country.
Supposed to be the first one in the
Safe
country.
house.
Yes, they call it Safe House.
It was
Yeah,
parenthetically operating illegally for a number of years prior to
Yeah.
its official sanction by the
Right.
city of Philadelphia. But
Yeah, then the city said it's okay, but then actually DOJ, and it was first DOJ under Biden, or was it Trump?
it was
won?
Bill McSwain. It was Trump won.
Yeah, so Trump
Yeah.
won, said you can't, this is not, this is illegal. They went to court, but then I believe the Biden administration kept that going.
Yep.
They agreed with the Trump administration on this and said, yes, indeed. And now, in terms of where it is, they lost and they're appealing.
Well, so to get into the nitty
Yeah.
gritty, they lost on the interpretation of the crack house statute, the text that we're talking about. The Third Circuit said I'm going to get the case history wrong, but I think it's the district court said, no, this isn't a crack house. And the Third Circuit appellate overruled and said, no, this really is in violation of federal law.
Right.
Now they're in the middle of some legal wrangling over
Right.
whether they can claim a religious exemption
That's right.
under the First Amendment to 21-856. That's ongoing.
Yeah.
But again, I think you get to this point here, the best appellate case that we have says, no, really, these things are in plain violation of the text of federal law. The highest precedent currently available, and the Supreme Court denied cert when they tried to appeal up to the Supreme Court, which means it stands as precedent at least till you get a circuit split.
Yeah,
It's unlikely.
Yep. So I don't know if you want to talk a little bit more. I mean, this is kind of gets into the
Right.
report, but please.
And I think the other thing to talk about with supervised consumption sites is the social problems that they can generate. And I want to be cautious in this because I think it is possible to design an SCS that doesn't generate extreme social disorder. Indeed, when they first started developing these things in Europe, the goal was specifically to suppress disorder, not to save lives. Right. The plot spits in Switzerland.
Switzerland wants to move it inside.
Yeah.
They don't want it in view. There was an old rail station with I talk about it in the book actually with the they called it needle. Had to call it Needle Park because it was just needles everywhere. And so they said, all right, this is enough. This isn't really about saving lives. This is about moving this inside so that tourists and others aren't affected by it.
So there's at least one study that concludes, I think in Barcelona, they reduced the level of trash. But then there's another study in Alberta that says, no, really, disorder increases around sites in Alberta at least. This is a graphic from the site, one of the two sites in New York City, which, as Kevin notes in the book and in the report, is 50 yards from a daycare center. I've been to the site. You get off at Harlem on 125th Street and you walk for like 5 minutes. You're right there.
Yeah.
And indeed, there are people who will congregate to use, people who will congregate to sell drugs. This whole area of Harlem, parenthetically, is just awash in drug support services because the city has just shoved them all in there.
Which is a huge community, community issue with
extremely unhappy.
Civil rights groups in Harlem. They don't want to see it because and it's not about their ideological opposition to consumption sites even. It's just that they have every methadone clinic in the city, every other social clinic there, now the consumption site. They already have open air drug markets. And so you have all of these in a 3 to 5 block radius. That's now an issue of environmental structural racism, actually, because you're moving this stuff. They would never open this in the West Village. I mean, I would love it if they, or in Soho or the Village. They just wouldn't.
A similar thing happened in Vancouver,
right?
Where Vancouver in the downtown east side, which is its main, its Skid Row, quote unquote, has something like 30 overdose prevention sites officially licensed. There opened one in the Yaletown neighborhood of Vancouver, which is slightly nicer place, and it generated a great deal of public upheaval. I've been to the Yaletown OPS before they closed it down.
Shut it down, yeah.
It was clearly generating disorder. I think that you look at there's a bunch of different literature on this, and I think the synthesis that I take away from it is possible to run one of these facilities in a way that doesn't generate disorder. It's also really easy to run one in a way that generates disorder, in particular, if it's the first one that you're opening rather than the 20th or 30th that you're opening. It can generate petty crime. It becomes a magnet.
Well, it's also like a political stance.
It's also
folks, right? Where this is sort of their political stamp is that we are opening this because we believe in harm reduction and by all means necessary harm reduction, and then it becomes a lot less about what they said to legislators and the public when they started to open it, which is they usually say we see this as a way to refer people to treatment. When you look at those numbers, it's like less than 1%. I mean, they're not referring
this
people
is
to
also
treatment.
relevant to, and I skipped over the study in the last slide, but there's a new study out from last month looking at two sites in Alberta, comparing them, showing that relative to the site that didn't close, in the jurisdiction around the site that did close, not only did deaths not increase, so again, no effect, but also utilization of medication-assisted treatment went up when the site closed compared to the place where the site did not close, which tells you that at least in that context, not necessarily everywhere, but at least in that context, people were deferring from getting access to evidence-based medication-assised treatment because they had access to the supervised consumption site. We should talk about costs, right?
Yeah.
Oh, yeah.
Well,
right. Well, and this gets to the point about it is again conceivable that you could build a supervised consumption site which has as its purpose getting people into treatment. Descriptively, that doesn't appear to happen very often. You can speculate as to why that is. You look at, for example, the fractions of the population who end up actually getting referred into medical treatment or counseling are a vanishingly small share of the people who utilize on a regular basis. Some of this is almost certainly an ethos thing. The people who operate these sites are often very wary of being seen to pressure or encourage or in any way suggest to people that they need to get treatment before they're absolutely ready. But some of it is also structural. If you're offering the idea of safer drug use without judgment, it becomes really hard to say, hey, maybe you want to get clean. Conceivably, you could get over that burden, but descriptively, that does not appear to have happened. And then do you want to talk about costs?
Go ahead.
Yeah.
Go ahead.
Oh, yeah. Well, and look, in my mind, the case about supervised consumption sites is less about the social harms, which can be real, but are a little harder to measure, and just a cost-benefit reality. States, cities, the federal government has a fixed pool of resources to spend on a tremendously real problem, i.e. the drug overdose epidemic, which remains an extraordinary social issue. We have stuff that works, and we're spending money on stuff that doesn't work. That's the bottom line. If you look at the total costs associated with facilities, opening and operating these facilities, which require multiple on-site staff, which require physical space, millions of dollars to operate them. That money can go to naloxone, which in terms of cost benefit probably generates about $2,000 in benefit for every dollar in cost. It can go to medication-assisted treatment, buprenorphine, naltrexone, methadone. All of these things are relatively cheap. They're easy to administer. The fixed pool of dollars that we can theoretically invest in a supervised consumption site can instead be focused on treatment, prevention, indeed even reasonable harm reduction interventions that actually work to reduce harm, unlike supervised consumption sites, which do not.
Yeah. And I think one of the things I would say about it is when you sort of step back a little bit, you think about the nature of addiction. One of the things we know is that most people who are addicted to drugs don't think they are addicted to drugs. They don't think they have a problem. The vast majority don't think they have a problem. And then when you think about how could that be? It's actually not that difficult really to think about because drugs are a pleasurable activity. I mean, and your brain is telling you, and Bob DuPont talked about the brain being the most selfish organ in the body. Your brain is saying everything's going great. I mean, your world might be completely crashing around you, but things are going well. They're going well for your brain because your brain's getting these constant hits of pleasure. So of course they're going well for your brain while your world crumbles. And so it's difficult to actually say, admit to having a problem. That's why it's the minority of people with a problem will admit to it. And we all know this with alcoholism as well, that, very few people with a problem actually admit it. And so when we think about interventions, I think we have to think about how do we spend money on finding interventions that help people realize they have an issue or people around them, loved ones helping others realize they have a problem. That to me is key, because if we're only relying on the individual user and we're making it safer, quote unquote, even though we're not really, but telling them that it's safer, we're making it easier, frankly, and more comfortable to use drugs, I think it then becomes very difficult to sort of make the case that actually, no, this is a problem and we want to see you, in recovery. And of course, we know that recovery is very real. There's tens of millions of people in this country who are in recovery from addiction. And we need to keep reminding people about that. One of the sort of underlying, very stated, I was gonna say indirect, but actually very direct statements made by health officials in Canada when they were launching these kinds of things is that, well, and this is a quote from the main health officer in British Columbia, is that she said, well, recovery from opioid addiction is just unrealistic. That it's realistic for alcoholism, but not opioid addiction. And that's the kind of, I would say, very dangerous thinking that is obviously not going to be promoting recovery. It's also just wrong when you look at the facts. But again, this is where I think when people think it's so desperate, there's nothing that folks can do, they often sort of turn to these kinds of ideas.
I think we want to kick to questions.
Yeah,
soon,
yeah,
but,
we'd love to have questions.
Just to close, offer last thought while people think about their questions. I think the drug crisis is such a substantial issue that it's a little bit, you have to put ideology to the side, right? And I think about needle exchange. There are a lot of folks who are uncomfortable with needle exchange. They think it's sort of morally unpleasant. They don't like the idea of quote unquote enabling drug use. And the response is pretty good evidence. Needle exchange reduces HIV transmission, saves lives. Okay, that's a pretty good argument in my book. The case for supervised consumption sites has always rested on the assertion that the evidence says they save lives. Whatever else you may think about it, the evidence says they save lives. And at this point, my response is the evidence does not say that they save lives. The evidence pretty decisively says they don't save lives. And if that's the case, then if we believe in an evidence-informed drug policy conversation, then we have to say, okay, these interventions do not work. In much the same way that we should be happy to say needle exchange works, we should look at what we know about supervised consumption sites and say, we did the experiment, it failed, let's move on and deal with the reality on the ground as it is.
Great, thank you, Charles, for this. Are there any questions from anybody in the audience, or thoughts, comments? Yes.
Yeah, I have one. This is kind of like a community impact. Like, how do local crime statistics report change within a 5-month walk? Or have you looked into that research? I know you guys briefly put it up there.
There's a couple of different. There's one study that relies on. Okay, so it depends a little bit on what you understand as your control group. So there's one study that looks at the supervised consumption sites in New York, and the blocks on those. The blocks where the sites are situated, and compares them to other high crime or high drug use sites. If you have a methadone clinic on your site, if it's a high crime block in the city. And the answer is there's no difference between the supervised consumption site compared to that control group before versus after the supervised consumption site is opened. That to me is a plausible argument that a supervised consumption site doesn't add a lot of disorder to an already disorderly environment. There is, on the other hand, some evidence that says compared to a synthetic control, I can get into what that means, of other blocks that are similar, there's an increase in certain kinds of disorder-associated calls, I think in particular shoplifting calls. But all of that evidence is sort of only valid within the context of, like, if you have an area of high concentration of service and you slap down a supervised consumption site, it's already a magnet, right? It's already a space where users are going to come and therefore dealers are going to come and therefore a drug market will emerge. That's already true. You're not making much of a dent. On the other hand, to return to the Yaletown example, and there are, I believe, police statistics from Vancouver that bear this out, if you drop a supervised consumption site in a neighborhood that does not have one, if you go from 0 to 1 rather than from 19 to 20, you will see an increase in concentration of users, therefore dealer-associated activity, which means crime.
You want to talk about the study that in New York that showed basically they were bragging about a reduction in crime. And I think it was Henry Husak from Manhattan Institute said, sort of looked at the statistics and they found that they were not counting all the crimes. They were counting certain crimes and not others. I mean,
I'll leave this to you because I don't remember.
This is where these studies. I don't want to misquote the study, but basically there was a study on New York showing there was a reduction in crime. It was like, oh, interesting, a reduction in crime, not even an increase, just a reduction. And when you actually looked at the way that they counted crimes, they left out whole classes of crimes. And that this is sort of in line with what Charles was saying about some of the Canadian studies that have looked at this, that have looked very positively. The devil's really in the details when you look at, crime statistics and when you look at kind of the specifics of some of these studies, because I hate to say it, but some of the researchers, especially the early researchers who looked at these things, they're also activists. I mean, these are people who were like there at the ribbon cutting ceremony of the injection site. Well, if you're there at the ribbon cutting ceremony, maybe you shouldn't be the person evaluating it from an objective point of view. And that's unfortunately what we've seen. Yes.
Why does there seem to be a trend sometimes in policy where like the drug issue is very complex, homeless issue, there's like short-term solutions to these very long-term issues?
How long do you have? We could be here for a very long time. I mean, well, I'll just say then, Charles, I won't say which. I worked for both Republicans and Democrats. I won't say which one it was, but I was told very bluntly once, if it doesn't fit on a bumper sticker, we're not interested. And that really is this idea that our political cycles the way they are. People want wins. You're not doing something that's laying the foundation for it's going to be positive in 20 years or 15 years or 10 years is a difficult sell politically. And a lot of these issues get politicized very, very quickly, and they shouldn't be. So.
Yeah, well, and I think I almost agree with that. On the other hand, I kind of want to reject the premise of the question, which is that in some senses, in both the drug and homelessness policy spaces, we become too fixated on the root causes.
Sure.
The goal, the harm reduction mindset in some senses is we need to prevent harm until people deal with the sort of core issues that are driving their behavior, until they really are able to deal by themselves with and it's like, no, they kind of just need to go on methadone. Like we have medications
things that work.
They work pretty well.
Yeah.
They're not perfect, but they work pretty well. Like,
Yeah.
The same thing, not to get into homelessness policy, but I think it's the same thing in the housing first discourse, where there's insistence on until we address the fundamental lack of a home, we're not going to be able to deal with all the exogenous associated problems of homelessness. And the evidence says actually that's not true. Housing first doesn't accomplish that goal. It doesn't deal with the externalities of homelessness. It just deals with putting people in homes. And there are lots of other interventions that are just like rapid rehousing, that are drug use interventions, just mental illness interventions, that like are in some senses about putting a Band-Aid on the problem, but Band-Aids are often helpful. So I think policy is never going to be very good at addressing those root causes issues. They're really hard because they're root, right? It's why are people addicted to drugs? Well, as Kevin said, drugs are a lot of they're very pleasurable, and it's hard to change people. But I think that the evidence-informed policy often can tell us what is a way around that issue. It's just that not all of the ways around the issue are as effective as we think they should be at first blush.
And actually, you could argue housing first is a Band-Aid, but not the way, because that's actually, you could argue the other way, right? It's not because if we're actually saying that you need to deal with addiction before you give somebody a 2-bedroom apartment, that doesn't mean you don't want to have shelter, but we're not going to go down that rabbit hole. But it's interesting how these can kind of work both ways. Yeah.
Yeah, I think it's great to hear you
Thanks.
all discuss this. I'm in recovery for 38 years.
Thank you. Congratulations.
And 2 kids.
Right.
Well, one in prison, but somewhat in recovery, and I've been working in treatment as a therapist for 38 years as well. I can see this has always sort of been the quick response. I love the bumper sticker idea because I think it's very true.
Yeah.
Over the years of working with multiple administrations. But I do think, I look at Tennessee specifically, we deal with it a lot, and it's fine. Its money is put in the wrong spots versus harm reduction is in terms of naloxone. In terms, in Tennessee specifically, we have about 8 people dying a day from overdose. We think, but the real that's very disturbing.
Yeah.
The most disturbing is 4 of them are on the waiting list.
Right.
Yeah. I just talked to the commissioner yesterday, and we still can't get to that place to say, there's all of these things we're looking at. There's all of these committees. The opioid abatement money is going here, going there, going into this. And I said, well, we need 4 more beds.
Yeah.
You know what I'm saying? Not to spite you.
Yeah.
You can do a lot. So
No, sometimes there's a very easy, it's just like, it's actually not so complicated. Yeah.
And I think you all are, it's also very well thought out, but it's very practical. I'm a very
Right,
practical
right.
guy in meetings all the time and dealing with addicts every day. And I think the practical approach is very smart.
Yeah.
Consumption sites. I mean, as an addict, I can tell you that it's never.
You would have liked them.
Well, I would have said, I like it.
Yes.
But there's a lot of, it's a short term.
Right.
I can go in there and use pretty quick. Then
Right.
I'll buy some dope on the street.
Right, exactly. And then use somewhere else when it's closed.
Use somewhere else.
'Cause it'll be closed at 7 o'clock.
It says I saw something that said an hour wait.
Right,
I mean, I'm shooting dope all day.
right,
If you're not shooting dope all day.
And
you're really
fentanyl.
not an addict.
right,
You know what I mean?
exactly.
You're like casually
Right.
drinking a beer or something.
Right.
So it's not a logical, it's a very illogical way to address the
I
problem.
want to I want to stick on the treatment point for just a second,
Mhm.
and partially because it's one of the questions here is what can federal policymakers do, and I
Mhm.
think we talked about this a little bit in the
Mm.
in the report, but I think there are steps that you want to take in handling federal harm reduction funding. You want to make sure fundamentally that federal harm reduction dollars are flowing to evidence-based interventions and not illegal evidence-free interventions, or interventions where the evidence say they don't work. That involves enforcing the executive order on 856, but it also means that SAM-HSA and NIDA and all the other grant-making authorities should be looking at, are we actually saving lives? But then the other point is about treatment, right? And I think neither Kevin or I are sort of like hardcore drug warriors. We need to put 1 billion people in prison type of guys. The emphasis is on treatment and prevention. And to your point, we really have a fundamental lack of treatment infrastructure in the United States. And we lack a spectrum of treatment, right? We lack access to outpatient treatment, therapy-based treatment, medication-assisted treatment on an outpatient basis, medication-assisted treatment on an inpatient basis, long-term stay for treatment. Our voluntary treatment infrastructure is inadequate. Our involuntary treatment infrastructure is inadequate. And a lot of that does come down to what federal dollars prioritize and where the federal dollars are going. And, it is possible for states are always going to be the front line because that's where the public health infrastructure is. That's just how it works in our constitutional system. But the federal government is in a position to make serious investments in treatment beds and ensure that when people are ready, when people are ready to get clean, there's a bed available for them on demand immediately. And B, encouraging the infrastructure to push people in that direction, whether it be jail diversion, police diversion, whether it be ensuring that all recipients of federal funds are pushing treatment at the point of interaction, whether it be encouraging states to adopt involuntary treatment where appropriate and evidence-based.
Right.
You gotta eat. The feds can do a lot to give people capacity if they want to.
Yeah, it reminds me of the famous evaluation of the DC drug court 30 years ago, which said that this evaluation found that it was very easy to change addict behavior, but it was very difficult to change judge behavior. And this is part of the issue, is that there's a whole public administration system around things. I mean, if you look, we could have a discussion separately look at the probation system. We have 5 out of 7 people in the criminal justice system are not in jail. They're in the community. They're on probation and parole. We handle them terribly. And we know, by the way, 85% of who's using drugs in this country problematically. They are in the criminal justice system for other reasons, not for drug crimes. They're there for, violent or other nonviolent crimes related to their drug use and their addiction. And yet we're still not sort of doing what we can do, knowing what works, knowing what treatment works, knowing what treatment doesn't work, knowing that incentives work. I mean, we know the levers. It's just a matter of actually putting it into action that we've always had a hard time at. Yeah.
Where do they get suits so more in HHS? Where?
I mean, there's all kinds of, again, at the state and local. So I would say most people who, are interacting with the system are doing so on the state and local level. It's actually not a federal issue, a lot of it. So on the state and local level, that's really where drug policy is really important. And yet we don't really talk about that very often. We don't talk about what can police forces do. For example, when somebody is, using to divert them to a program that basically says you can either go here or you're going to go to jail. I'd rather not put you in jail. I'm going to be very fair, but if you don't show up for your drug test or you don't show up for treatment, you will go to prison, not for 10 years, maybe for 10 days, but long enough that it's unpleasant. And certainly, the fact that it's not random, the fact that it's certain, like this will happen. It's not going to depend on things. Mark Kleiman used to talk about, the swiftness and certainty being important in terms of crime to actually deter further crime. Swiftness and certainty is more important than severity. It's like getting your kid to clean their room. Right now, our system basically tells that kid, if you don't clean your room, there's a 50% chance that in 6 months, I'm going to ground you for 2 years. As opposed to, if you don't clean your room, there's a 100% chance you're not going to the movies that started an hour with your friend. It's up to you. And we don't do that. We do the latter, and then we wonder why. So there's a lot we can do with the criminal justice system. I would say it's one of the huge levers. Healthcare system is another lever.
Yep.
Our physicians are not equipped. They're not trained.
I can really get to the nitty gritty. We have limited time, so I just want to answer at the very abstract level, which is HHS and DOJ. Most of it's dollars that are flowing to the state and local because that's where the health authorities are.
Yeah. Yeah.
HHS first and foremost. Is,
SAMHSA.
Yeah, SAMHSA. NIDA a little bit and how they fund, but there's also some DOJ programs that are earmarked specifically for drugs and drug use, drug courts, trying to fund drug courts at the local level. I mean, I think what you need at the executive level, I know we're talking on the Hill, but at the executive level, what you need is, and indeed this is something you can write into statute, a mandate that recipients of federal dollars are either either evidence informed or evidence generating, and I can define those terms, and B, that the outcome on which they are focused is people in remission from drug use, from drug addiction, and lives saved. Simply holding recipients to those standards will clear a lot of the dross and make sure that dollars flow in their place, because they're not currently held to those standards.
Yeah.
I think we have one more question in the back. We got.
Yes.
So I think it's really just an incredibly powerful point of you saying that these centers really serve not to usher off into recovery and sobriety to make it easier, more comfortable to use.
Yeah.
I'm just curious, is there any data out there that you're aware of that indicates, in some sense, people who come into these sites, do they who they account close friends and or close family? In other words, sort of, there's the government support, and obviously we have a dearth of that, but sort of in just civic society, familiar friendship. I mean, I have to imagine these people who come in really lack any sort of even one meaningful friend, one meaningful family member. Is there any data out there on that?
I don't know.
I'd have to go digging. I don't know the answer off the top of my head. I suspect the answer is maybe, because there's a lot of surveys of users of these sites, but mostly the surveys are designed to reach a certain conclusion.
Yeah.
Whether they would select for that measure is an open question to me. But somebody might have done it. A lot of people do surveys in the space.
When you have the head of one of these injection sites wearing a T-shirt advertising a New Jersey marijuana retail chain for his New York Times close-up profile, you kind of realize something is wrong. This is somebody who's interacting with people. He apparently supposedly is trying to get people into recovery, because that's what it's told. We're told this is a way to get people into recovery who can't easily reach. And he's wearing a shirt promoting drug use. It just kind of shows where the head is sometimes, even if other intentions are good, but really that actually trying to get them to stop using is not really a goal. And I'll just end it here. Addiction is the only disease where you're a better person after you had it than before you had it. And so the goal is to get people into recovery as quickly as possible, and as obviously safely as possible, as efficiently as possible, but as fast as possible, because every day could be their last. And this is the kind of urgency that I think we want our federal, state, and local lawmakers to have on this issue. Thank you all for coming. Appreciate it. Thanks everyone online as well. Thank you. You can read the report online. You can also go to gooddrugpolicy.org, where our website is. Thanks. Thank you, Charles. Fun.
Good time.
Thanks a lot.